So for everyone that has tuned in so far, we'll probably get started in about 5 minutes time, and we'll be ready to go. So I'll maybe just wait for a couple minutes past 1, and then I'll start going through my spiel. Okay, we'll get started in just a couple minutes. We'll give a few more people a chance to log in. Hi everyone, we're going to get started in just a minute here. Okay, I think we're about ready to go on our end. We'll get started right away. So thank you everyone for joining us today. Hopefully you can all hear me. If you're experiencing any technical issues, type into the chat box or you can email membership@caucus.ca. So I'm just going to introduce myself quickly, then we'll go into some housekeeping items and I'll introduce our presenter and we'll be on our way. So my name is Susan Ammer, and I'm an accessibility advisor at the University of Alberta Student Accessibility Services. I'm also the Alberta representative, one of the Alberta representatives for the community of practice, the Accessibility and Inclusion Community of Practice. So just a few housekeeping items. We're going to ask that questions be primarily entered through the chat function. So any clarifying questions that can be answered quickly throughout the webinar can be entered into the chat function, and I'll be monitoring that, and we'll do our best to address them, just the quick ones as we go along. So I'll read the question out loud, and then we'll have Barb answer them. For questions that may spark a longer discussion, we would like to save those questions for the question period at the end, which will be about 15 minutes long. So if the chat function isn't working for you, or to clarify a question that you asked by speaking into the phone, you can unmute your phone by pressing *7, and then to remute your phone, you can press *6. So we'll try to get through as many questions as we can today. If we run out of time, any unanswered questions can be sent to Barb, and she will be including her contact information at the end of the presentation. So unfortunately for closed captioning, there were some technical difficulties. So throughout the webinar, there won't be any closed captioning. However, a transcript will be sent in 24 hours to those who requested closed captioning. And just a note to everyone that the webinar will be recorded and posted to the Caucus YouTube channel. And in 48 hours, everything will be circulated. So the PowerPoint will be circulated to all of the participants. Okay, so that's about all the housekeeping items I had. So I'm going to introduce our presenter for today. So our presenter is Dr. Barbara Roberts, who has a wealth of knowledge and experience in the field of accommodation and higher education. She's a licensed occupational therapist, and she's been working in the field of accommodation and higher education for over 20 years. She completed her PhD on the framework that can be used when making decisions regarding accommodations during clinical placement. So that's what we're all here to learn about today. She also serves as a consultant specializing in disability accommodation and dispute resolution, and has provided consultation to human resource departments, schools, post-secondary institutions, parents, students, employees on disability-related issues. And she's the founding executive director to the Work Life Office and senior director to the provost at Michigan State University. So Barb, thank you for joining us today, and I will hand it over to you.
Well, thanks so much, Susan. I just have to say what a real pleasure it is to have this opportunity to talk about some of my work. Some of you out there I know are lifelong colleagues. Hello, Mark. It's really nice to know that folks that I really learned all of this from are still interested in talking about it and listening, and I really look forward to your joining in the discussion. And I hope as we go through this that people will think of examples that they'd like to talk about in the discussion section. I should just mention, too, that a lot of this is based on a professional development session that I did last year at University of British Columbia with a group of colleagues there and from Queens when we put on a clinical accommodation and clinical education professional development day there. So if any of you were there and this looks a little familiar, there are some overlaps there. So what I'm hoping to do is, as Susan said, we'll take some questions and kind of monitor them there in the chat area. And what I'd like to do is just lay out some basic concepts that help us situate ourselves in the work of accommodation in clinical education, and then go through some of the key questions that I use when I'm trying to decide if something can be accommodated or not in a clinical setting. So before we jump into any of that, are there any questions at this point that are
So far,
burning questions? Okay, no burning questions.
So far, I don't see any.
Okay, and I just have to apologize if the animation seems a little awkward. It doesn't work in this platform, so I had to make a separate slide for every animated point, so bear with me if that gets a little bumpy along the way. So for instance, this first slide, can everybody see all the slides? We're all good out there. Susan, can you see those?
Yeah, I can
Okay.
see this. I haven't heard that anyone can't, so I think we're good.
Okay, so this is basically a model that I developed in the course of my work in disability. And if you look across the top there, we have 3 different contexts that we use when we're thinking about accommodation questions. So we have a social context, an educational context, and a legal context, right? And under the social one there on the left in yellow, there are different ways of looking at disabilities. So we're all familiar with the medical model, which says, oh, the student has a problem, and therefore we experts should come up with a solution to that. And I think we're pretty clear that that's not the way a lot of our offices work, but nonetheless that way of thinking is out there, and that kind of underscores the role of documentation, for instance. And then we also have a social model that says, no, it's not about the student, it's all about the environment. And the environment is the problem, we need to fix the environment, and the student is a key player in developing those accommodations with disability staff and faculty around their particular curriculum. So a much more progressive model, one we've been moving towards, I think, in the field for some time. The World Health Organization, however, takes those 2 models and combines them into what they call the biopsychosocial model. And what I like about that model is that it acknowledges that some differences in bodies exist and that an individual must participate in making their participation equalized, but there is a big role of the environment and the barriers and facilitators that we establish when we develop education systems. So it kind of brings it all together and says, you know, there is a body that we're working with, there is a set of expectations, and everybody needs to work together to remove those barriers. So that's kind of the social context where we're situated. And in the educational context, we have this curriculum, and in this case we're talking about clinical education. So we're looking at nursing, medicine, rehab, teaching. And so we've created a curriculum and an environment, both a physical and a practicum environment, in which there are required tasks and activities, and there's evaluation. So that's the program. The student comes to that with whatever their body does and how it works, with the activities they engage in and the limits they encounter, and how they participate or are restricted from participating based on environmental factors. So we put those 2 together in what is considered a joint intention for learning. So the student wants to learn the curriculum, the institution wants to teach this curriculum. How are we going to do this together, given all those variables, right? So then we have the blue bubble over here of the provincial human rights codes that say, oh, while you're about this business, you need to make it individualized, you need to protect the essential requirements, and you have to do this to the point of undue hardship. So we have an imperative there in our legal context where we've also invented a bunch of rules that say, let's make sure we make this fair to everyone. So when we bring all of that together, we end up with the bottom blue, orange, do I know my colors? Green bubble there that talks about an accommodation plan, which has to be individualized, including the student, protecting essential requirements while we remove barriers and identify facilitators. So this just kind of gives us a graphic and situates us in where we're talking about this. So we're talking about how to get people to do clinical curriculum with a variety of abilities when we come together to make a plan to work through that. So where does that take us? Let's look at some definitions. So the definition of disability often in our work arises from our provincial codes. And in this case, I put up the Ontario code. It's quite medical model, as you can see. They're talking about the body, So it's a degree of physical disability, infirmity, bodily injury, clearly a medical kind of definition. However, if we look back at the origins of the social movement and the social model of disability, the organization called UPIAS, I don't know if anybody goes back that far, but UPIAS stands for the Union of the Physically Impaired Against Segregation. Okay, it's old, but it's a seminal idea that disability is something imposed on top of our impairments by the way we are unnecessarily isolated and excluded from full participation. So you can see where that idea is beginning to point to the building of an environment that excludes people. And so the World Health Organization's definition comes in and says, actually, a disability is the outcome of that interaction between a person's health condition and their contextual factors, so the environment we have built. So the disability really is in the interaction between how someone with various capabilities and physical characteristics interacts with an environment with different characteristics. So we're starting to see here that the definition is really moving towards equal consideration of the person and their environment. So that brings us to how we build environments and where do we as disability officers intervene. So if we look at the World Health Organization concept, there's this notion of a health condition that affects how people participate. It affects their body structure and function. That relates to how they participate, what activities they engage in. But really, the part of that we work in is not in fixing the body structure and function, right? We're not the rehab folks. We're not the surgeons. We're not the doctors. We don't fix the body. We accept the body the person brings to the interaction, and we deal in the environment. So we build an environment that is more or less accessible to a wide variety of participants. So that situates us in the environmental factors piece. Well, what are environmental factors? So the next slide tells us there are 5 of them, attitudes and beliefs, and I'm sure you can all relate to the vast amount of work we do on that one. Products and technology can be barriers if they get in our way, or facilitators if they make it easier, like assistive technologies. Natural and built environments, we create those when we design a building with or without stairs at the front, or with or without ramps. We create a more or less accessible environment in relationships and supports that we provide, and particularly in higher education, the policies, services, and systems can really be barriers for students with disabilities, right? And that, when you take that into a clinical world and you're working with someone else's policies, services, and systems, so the hospital, the school setting, the courtroom, then we're looking at an interface of all kinds of imperatives that say, oh no, this is how we built this thing, this is how it has to be. So that's where we can have some influences in those environmental factors. So when we look at what's really the focus of this work, the Supreme Court would have us feel that it is not actually about the impairment, it's about the way we treat people. And I just like to include this quote because I find it very compelling from the Granovsky case, that the Charter of Rights and Freedoms is ultimately concerned with human rights and discriminatory treatment, not with biomedical conditions. So in other words, it's not so much how disabled are you, or do you have a condition that fits the DSM or our criteria, but have we created a system that excludes people? And the quote goes on to say, while the notions of impairment and functional limitation are important considerations in the disability analysis, the primary focus is on the inappropriate legislative or administrative response of the state, or in our cases, the institution. So even the Supreme Court would have us look at how we structure our educational experiences, ergo our clinical experiences, to make them more or less accessible. I'm going to kind of take a leap here and assume that everybody on this conference call knows about the duty to accommodate, or you wouldn't be in this business. And that's mandated at the provincial level. So while the Supreme Court may have some opinions about this, the real imperative comes from our provincial legislations that talk about how educational systems must not discriminate and that disabled students have equal access to educational opportunities, right? So we have that. So let's look at some elements that contribute to that whole construct. So you kind of get that I've been talking about how we build institutions and educational curricula and how we deal with political structures, and those structures that exist in clinical settings. So if we've invented those, chances are we could reinvent them, right? And that's really the bread and butter of disability accommodation business, is reinventing the way we deliver education so more people can participate more equally. So education itself, the way we deliver it, the curriculum choices we make, are things we as human beings have created in curriculum, as is the concept of disability, where we ascribe meaning to different kinds of impairment or function. And in fact, the entire human rights paradigm is an invention of human beings. So if we have those three concepts that we now are implemented, and we find ourselves caught in the crux of these competing things, we have to remember that what's been invented can be reinvented. So how do we do that? How do we reconcile the conflict between what the duty to accommodate would have us do, the curriculum we've built, the specific requirements of clinical education, and our students who want to be practitioners? So that's where I felt that an analytical rationale was needed, something that would help us think through that reconciliation consistently and fairly, even though every student's curriculum and disability interface is different. So there are no, you can't go look up what this disability in that curriculum should do, because there's a person in there. So we need a way of thinking that gets us through that process. So do we quantify the disability and say, oh, you qualify for accommodation, or oh, you don't qualify, which gets into splitting hairs and evaluating people, and we all love that so much. So what if we analyze the environmental demands instead? So if we're going to construct the academic requirements in collaboration with our colleagues and faculty who set those requirements, the environmental demands of schooling, we're going to have to analyze those requirements. So how do we do that? We need a tool, or some tools. Some of you will recognize this. If you weren't all on mute, I could hear you laughing hysterically, because lots of you have seen my diagram before, but it still seems to be useful. So we look first at whether there is a health condition, and if not, maybe that's not the ballpark we're in at all, and we stop. If there is, and that presents a barrier to the student's participation, maybe there's a skill we could build. Maybe there's a part-time course load that would fix it. Maybe there's a piece of assistive technology that would fix it. But if not, we're still looking at whether what the student is requesting is appropriate to the condition, right? And if it is, and the essential requirements of the curriculum are maintained, that's where we go and accommodate. If the essential requirements are compromised, we might have to revisit that accommodation. Is there something else we could do? Is there another way to accomplish this? Until we finally end up at the bottom there in the green bubble and we provide accommodation. So that's just kind of the basic process of getting there. But then what do we do with the essential requirements in clinical education? So I based a lot of my work on that of Kay Ashworth from Sinclair, Ohio. And Kay, I don't know if any of you were at this AHEAD presentation a very long time ago. Kay works in an occupational therapy program, so clinical education, and looking at how we analyze the academic requirements for whether the student can be accommodated or not. And Kay put forward 9 questions, and they looked like these in terms of a decision-making protocol. Is it an essential requirement and there's nothing you can do? Is it maybe not essential and you could be accommodated? Is it a cognitive skill? Is it a physical skill? So all those questions you see on the screen there speak to analyzing what? The skill, not the student. None of these questions say, can the student jump over a fence? Can the student read print? Right? They look at the task. So I thought, oh, if we had a way of analyzing these tasks, then we'd have a fair way of looking at what can or can't be accommodated without judging the student. So the Human Rights Commission gives us cases that give us what's called the 3-step test. I'm sure lots of you are familiar with that, based on the Mayoran case. And there's a 4th question that I really like to use as well. So let's have a look at those. So the questions that a Human Rights Commission will ask you if you're accommodating or not is whether the requirement is, first of all, established in good faith. Well, we don't really invent these things out of nowhere. So typically an academic or a clinical requirement is going to be established in good faith. In fact, it's probably going to be grounded in something quite concrete in clinical education. It's going to be grounded in something like, yes, a kindergarten teacher has to multitask because she has 25 kindergartners and an EA or two to supervise while delivering curriculum and making sure the fire bell doesn't go off, right? That's definitely in good faith. It's grounded in reality. Is the requirement rationally connected to the job or intention it's purposed for? Well, yeah. Again, we don't make these things up arbitrarily. Who has time to teach that? But here, the last question is really where the rubber hits the road. Is there evidence that you have to do it this way? And that's where we need to stop and say, why does this clinical task have to be executed in this particular way? And is there no other way to do it? What's the evidence? What's the rationale there? And that's the point that makes us look deeper at how and why we want students to perform as we do. So that gives us a set of questions we can ask of the curriculum. Again, these don't focus on the student or their disability or their functional capabilities. It's all about why the thing needs to be done the way it's being taught. So if you take Ashworth's notion that with a set of questions we can analyze the task, and the questions that we use are the 3-step test from Mayoran and the fourth one I'll get to in a minute, then we have a tool, then we have an analytical rationale for what we accommodate and what we don't. And that helps us define what is an essential or bona fide requirement, because it can't be adapted for a very legitimate reason. And most importantly, that reason has been examined. It hasn't been assumed. It hasn't been taken for granted. It's been examined using a set of consistent questions. Okay? It's really odd to do this without being able to see or hear any of you. I just have to say, I feel like I'm blathering endlessly, so I look forward to your questions. So here's the fourth question that I find really helpful after you've gone through the sort of structure, the notion of a structure, as Ashworth gave us, the 3 questions that Mayoran gave us. Let's look at this fourth question. So is a clinical requirement socially constructed, or is it invented or designed or developed by educators such that it excludes specific groups, and here we're talking about students with disabilities, for a reason that is irrelevant? So it's based on an assumption, or we've always done it this way, or I never thought of that, or we don't have a tool that'll do that. Oops, I keep missing my clicker here. Is it based about an assumption about function or about the group? Oh, people with learning disabilities could never do that. Or somebody with a physical disability could never be in a classroom, right? Is it based on those kinds of assumptions? So this question I find really helps get at the reasoning for the academic requirement or the clinical requirement. And it may be that, in fact, it's an excellent requirement, and it is having to be done as it's portrayed, and we can't accommodate it. But we owe it to our students to think it through rigorously with a consistent approach before we say no. And that's our job in getting clinical educators to think that hard. And sometimes they get real offended when you ask some of these questions. So just pony up your bravery there and have an intellectual discussion with them. So practicum settings, I think, are the most challenging, and that's why we wanted to focus on this today, because of those real-world implications. So when we have somebody in an emergency room who's a nurse with a learning disability, right, the scary, well, what are we going to do, how do we accommodate this, it's very comforting to go back and say, well, I know how to answer that question. I'm going to walk through these 4 questions and analyze this task. And if there is a reason and there is evidence of why you need to administer this med in this time frame without assistance, then you have a legitimate reason to go back to the person and say, wow, we've really thought this through, and we can't find an accommodation that doesn't risk someone's life. You have to suture this person this fast or they're going to bleed out. It's not about you. It's not about my assumptions. It's about how fast a body bleeds out, right? So it takes you into a very concrete and objective place to determine what can and can't be accommodated. So I've set this up so that we could stop at this point and maybe deal with some questions. I don't know if people want to go from here into the focus group results of my study when I asked clinicians if these questions actually do help them, or if you want to pause and take some questions.
I don't see any questions yet. We could maybe hold on for a second and see if anyone has any questions. Then feel free to just type them right into the chat function, and I
Okay.
can read them out loud. Yeah.
Sounds great. And we're close to the end, so maybe I will barrel forward here.
Sure.
So in my focus group that I did for my dissertation, which is one small chapter, I asked those 4 questions with clinical fieldwork faculty who worked in occupational and physical therapy. And I presented some of the background that we did here today. And then we applied those 4 questions to a number of situations. And then I surveyed them in a tiny little survey in the session to see how much they felt the questions were helpful in identifying clinical activities that can and can't be accommodated. And then we talked about that. So basically they said that the 4 questions were very helpful in finding what clinical accommodations can and can't be made, because they said it gave them an opportunity for deeper reflection on the rationale for the requirements. And that's really, I think, what is asked of us when we're going to say yes or no to an accommodation, is that we've deeply reflected on why the requirements are the requirements. And not just us in our disability offices, but clinical educators and clinicians who are out there determining how and why we treat people the way we do, which, by the way, is a moving target, right? We don't treat hip replacements the same way we did 20 years ago. We mobilize them in a day or 2. You don't lie in bed for 2 weeks. So treatment even itself is constructed based on research and what we learn about better treatments. So those things change. So how we do those things and why needs to be thought about. So these 4 questions helped the clinical educators reflect on that and give more thoughtful consideration to how and why they evaluate clinical skill the way they do. And I thought this was the most compelling quotation from a participant, which said she said, "It helped me make my reasoning explicit." And I think that's one of the biggest gifts we can give our students, is well thought out, clear reasoning for whatever it is that we need to do with them, and that's fair to them if we've really thought diligently about it. So I think this presents us with a really exciting opportunity to use those test questions as a creative opportunity to analyze the task, the curricular requirements of clinical education, which are the most demanding to analyze, in order to meet the needs of diverse learners while we ensure both clinical and academic integrity. And I just want to mention that using this kind of a protocol is also applicable in an employment setting. So where you have employees and you go into the workplace and say, what about this when, in the real world, we all get the real world question. Same thing, because the real world and the clinical setting where students are going to be employed also has a responsibility to accommodate, as do regulatory bodies, and we can get to that in a minute. But if we look at this from the same point of view, we're using a consistent rationale that says we're going to reconstruct the way we look at requirements in order to make them more accessible to more people as much as we can. And when we can't, we'll know why we can't. So there we are. And I think that opens it up for questions.
We do have a question here.
Okay.
So we have, can you give examples of the application of the 4 questions for fieldwork? And student has a required fieldwork course. Student has seizure disorder. Prof wants to exclude student from course for safety reasons. So I think that was maybe an example that they were giving.
Sure.
Okay.
Good question, Jody. Nice to hear from you. That gets into risk analysis, and we didn't touch on that, but there are 2 things you can do there. So if the student, the instructor is probably worried that if they send a student into a clinical setting of some kind, a fieldwork setting, and they have a seizure, that's going to put their population, whether it's kids in school or people in a hospital or something, at risk, right? That would probably be the worry there. And so what the instructor has to look at in that situation is there are 4 considerations for risk. I hope I can remember them. So what is the likelihood that the event they're worried about is going to happen? How severe is the consequence of what's going to happen? What can be done to ameliorate that risk? And there's another one, I can send them to you. But you can't just assume. See, that question is predicated on the assumption that people with seizure disorders are unsafe and they don't want to take a risk. Well, you have to really analyze and define and defend what that risk is going to look like, what can be done to prevent whatever they're worried about, and give the student an accommodated opportunity. Because you can't just go from A to B and say, oh, seizure disorder, can't be a classroom teacher, right? Because there are lots of things that can be done to make that very safe, and it's based on an assumption. Now, if the seizure disorder is really, really severe, it's uncontrollable, and the person is going to be responsible for interacting with other people in a safety sense, it may be that one of the bona fide requirements is that you can safely evacuate this classroom of 25 grade 1s when the bell goes off and the flashing light goes and, oh, your seizure disorder is photosensitive? How can we accommodate that? Can we accommodate that? And if we can't, maybe you need an assistant in the classroom, or maybe it can't be accommodated. But the point is to think it through very vigorously. What is the requirement, for instance, to be seizure-free? Apply those questions. You can probably do whatever it is with the level of seizure that someone who's successfully gone this far in school is managing, right? They're managing being in the classroom. So how can you do that? And if not, why not? And have you analyzed the risk sufficiently? And apply the 4 questions of risk analysis.
Okay, awesome. Thank you. So we have another question. Course requirements are often used as pseudo-occupational requirements. So a sociology course requires people to participate in discussion groups, and sociologists will need to participate in discussions. To what extent can course requirements stand as a legitimate barrier?
Oh, perfect question. So this is not just about clinical education. Okay, good. So participation can happen in many ways, right? So you would go back to that scenario and say, okay, in this sociology course, people need to participate in discussion groups so that you can spring ideas off of each other, respond in vivo to your classmates' contribution. But is that the only way to participate? And why does it have to be in that only way? So could the person, for instance, write responses in a journal and submit those to the instructor to show that they're thinking and they had a response to the comments in class? Can they type them in real time and they come up on a screen? What does participate really mean? And given what the course is, I mean, there are lots of kinds of sociology courses. What are you teaching such that it has to be taught with in vivo discussion? And you get more into that with seminar courses where you've already got some didactic background, you've done your reading, you've listened to your lectures, you've written your papers, and now we want to hear your thinking out loud in real time in reaction to other people's ideas. Okay, then we need to look at a variety of ways to do that. And why is the way they're doing it the only way? So what is the evidence? Go back to your third question there. What is the evidence of the necessity to participate in this way? There may be lots of ways to participate.
Okay, awesome. Thank you. A couple more questions. So please may you review how to respond to faculty that state, we have always done it this way.
I don't mean to laugh, but I've heard that so many times. It's like people who say, well, we've done something badly for a long time, so we just want to continue doing that, right? Like, just because we've done something a long time doesn't mean it's the best way to do it. And okay, without laughing, you need to, that's what the questions are for. So you go back and you say, well, we need to know why, even though you've done it this way all the time, why is this the only way to do it? So is doing it this way established in good faith? Well, actually, maybe not. Maybe it's just a habit. Is this requirement executed in this way? Does it have a rational connection? Or is it really just easier to use Scantron tests than essays? What's the rational connection to what you're teaching? And what's the evidence that doing it the way you've always done it is the only way to do it? Well, of course it's not the only way to do it, because 9 times out of 10 you're going to find a prof in another course that teaches it in a different way, right? Or you're going to go to another institution that says, well, we teach English literature in a drama class and we teach it in an online course. So clearly it's pretty hard to defend that that's the only way you can do it the way you've always done it. So there has to be a better reason than that. That is one of those questions that is socially constructed based on assumptions about the task. Right? That's the fourth question.
Okay. So I'm going to just skip one of the questions in the chat because, and I'll come back to it. There's one question I think that goes back to the previous discussion. I think it's referring to the one about the kindergarten teacher where you were discussing that. But the question is based on the last question. What if one of the high leverage practices of teachers is to be able to lead a whole class discussion? And I think that was, so maybe I'll get the individual that asked that question, maybe if you could just provide a little bit of clarification on that question that you were asking. And then we'll come back to it. How does that sound?
Or you could unmute and just reframe the question a little more in a little more detail.
Yes, so that individual, you can also unmute by pressing *7, and then feel free to speak and clarify your question.
Hi there.
Hi.
Yeah, so it's Teresa Soha. It was based on the discussion and whether a student needs to participate in in-class discussion as it relates to a classroom. So if it's in an education program where one of the requirements of teachers is to be able to lead whole class discussions, so where the teacher and the students work on specific content together and they use each other's ideas and resources. So, that's the one setting in a teaching setting, but then we require it in the classroom, for instance.
Mm-hmm. And what kind of disability prevents the teacher from leading a whole class discussion? What's getting in the way?
But wasn't that one of the disability is that the student couldn't participate in class discussions?
Well, I guess my question is about what would guide me towards what kinds of accommodations might be made. So if they can't lead a class discussion because they can't hear the class, you'd be going down one road. If they can't lead the class discussion because they're too anxious to stand in front of the class and handle it, that's a different road. But the question would be, how can the person be empowered to lead a class discussion? And that means breaking down what leading a whole class discussion means. What does it entail?
And what it looks like.
Yeah.
Okay.
So how big is the class? What kind of input are they leading it? Are they, sitting in an auditorium with 100 people? Are you sitting around a seminar table with 6 people? Do you need people to use mics? Do you need to use a talking stick so it's one person at a time? There's a lot of richness in leading a class discussion, just that sort of description, that could be unpacked to help find a way for the person to do that. There may be some interfaces of technology, for instance, that could be used for like when you have an online discussion and people put their questions in and somebody answers them as you go. You're still facilitating a discussion, but you're not doing it in vivo. So you'd need to know a little more about the situation before you could really answer that question, but hopefully asking the 4 questions will help you say, what is it about leading a class discussion that's necessary, and what's getting in this person's way, and can it be accommodated so that they can do it in a different way?
Right. Okay, thank you.
Sure, thank you.
Awesome. Okay, so we'll go back to that question that was skipped. So for a student with a mental disorder, in the context of fieldwork, they are expected to conduct themselves in a professional manner / conduct as outlined by professional standards. How do we break down the BFORs, BFORs, to decide if they can be accommodated or not?
So the person has a mental health disorder and they're in a clinical field, and so the question is professionalism, defining and defending professionalism?
Yes.
Okay. So when you look at that, if you look at the questions and you say, well, first of all, what is a professional manner that this person's not demonstrating? So you need to get a little bit more specific. So let's say they're a little bit impulsive. Maybe they interrupt the person a little too frequently when they're taking a clinical history, and they make the person feel like they're not being listened to. So they have difficulty establishing rapport because they're a little emotional and they're in an emotional situation. They're being evaluated, but nonetheless, that's a clinical skill they need to manage. So you would take that piece that they're not doing well and say, the reason we need you to do this is, and articulate that. Now, what would help you do that? So what will help you refrain from interrupting the client, establish better eye contact with the client, listen more thoughtfully to get a good detailed clinical history? We need to see those behaviors demonstrated. And so part of it comes down to breaking down what is professional behavior, and various fields are more or less detailed in that when they say what your clinical competencies are. And then if the person can't be accommodated to do that, there are times when, that is a bona fide requirement, that you set your patient at ease, that you have good rapport so you get good information from them for clinically sound reasons. And the point there is to be very articulate about the requirement and why it has to be done that way, and whether or not it can be accommodated or not, or why. It always boils down to the why. Why do you have to do what they're failing at? Why do you have to do it that way? And why can't you do it some other way?
Okay, thank you. So next question.
And feel free to email me if you want to talk more about that. It's more complicated than that, obviously.
And for anyone, if there is something that you want to clarify about the question that you asked, or add to that question, you can always unmute by pressing *7, and you can just start speaking if that works better for you. Okay, so next question. Would you please talk about the role, this one's a little bit long, but I'll go through the explanation. Would you please talk about the role of the disability advisor to, and in brackets, the vast majority who are not faculty, to engage in a discussion with academic faculty about whether essential requirements have been developed in good faith, based on research/standards and not designed to exclude particular groups. For example, a PT faculty, I'm assuming PT is meaning physiotherapy, says can't give student extra time to read/write response to written portions of the OSCE exam, whereas nursing faculty have made these accommodations. How to challenge faculty about the evidence they use to justify essential requirements?
Okay, so the question you want to ask there is, and then I can anticipate the answer you're going to get to. So help me understand why the student can't have more time. So don't jump to the other faculty of nursing and say, well, they do it, because that's just going to set up interdisciplinary tension, right? But what is it that they need this? Why is it that they need the student to give the written answers in this particular time frame? And they're going to come back and say, well, because when you're in a clinic, you don't have all day to compensate for your bad handwriting. And you're going to say, okay, but what if a student was allowed to type it on an iPad? Or what if they were, writing in a sense in a different way? What is so critical about this particular time frame in answering an OSCE? And the other answer you'll get is, well, because they're going from one station to the next and we can't hold everybody up. Well, you can have that person go last so there's nobody behind them, right? So that they can take a little bit of extra time. There are lots and lots of schools where they have allowed extra time. So I think it's important to get at what is important to this faculty member about this piece. And they're going to say, well, in the real world, you have to perform quickly. And so we're simulating the real world here. Well, when you look at the real world of how people take notes in a clinical setting, I can't remember the last time somebody was handwriting in one of my medical appointments. Can you? So what about dictation? What about typing? What about shorthand? So are there other ways to get around this? And mostly to help the faculty member think about where they're digging in their heels. What is it about this that's so meaningful to them? Isn't there another way we could do this? And if you need to go to other people who have done this, try to stay in the same discipline. Try to refer them to other schools where you know that they do have extra time on an OSCE to handwrite answers. Same thing like in a bell ringer, right, where they go through and they have to handwrite, and the whole class moves from station to station. There are lots of ways to get around that.
Okay, thank you. Next question, are you aware of any context where the educational institution and the regulatory body has collaborated to examine clinical competencies against the 4 questions for the purposes of enhancing access?
Okay. Yes. That's a big question. So I know of educational institutions and regulatory bodies that collaborate on the testing notions and sorting through how are we going to get this student who's gone through a clinical program accommodated appropriately through the testing, and so that the testing doesn't present a confound in what you're really assessing and the method you're using to do it, right? And that can be quite challenging because a lot of these tests now are increasingly, for instance, computer-based, which may or may not have accessible interfaces, or the regulatory body says, well, this simulates what we want students to be able to do in the clinic, and so that's why we set it up this way. Well, there are a couple principles captured in this question, and one of them is that you can't deny accommodation in one setting in anticipation of it manifesting in a future setting, right? So it is really important that they collaborate on both the determination of clinical competencies and the assessment of them, such that there's more coherence between the academic program and the reg exams. So that would be great if we could get them to do more of that. And then in terms of examining competencies against the 4 questions, yeah, that's where the challenge comes in. So when you say, well, we're examining this clinical competency in a registration exam or a clinical licensing exam, and we're not going to bend on this because of the rationale, you have to use the 4 questions to explore the rationale and see where that conversation takes you. So is this competency, as defined by the regulatory body, necessary to be done in this particular way, and what's the evidence that it needs to be done this way? Does that help?
Okay.
Krista, do you want to unmute and elaborate on that at all?
Okay, well, we can always come back to that one.
Okay.
If Chris would like any further clarification, feel free to unmute and
sure.
Just start speaking. Okay, next question. Any advice/ideas on accommodating lack of professionalism in health science programs? Certainly, clinical accommodations such as extra time with a patient chart or an extended rotation is now becoming commonplace in clinical accommodation plans. However, I am finding it more of a challenge to attempt to accommodate preceptors reporting a lack of understanding how to be/act in a professional manner.
You know, that's a really good question, Max. Thanks for asking that, because it comes back to the previous person's question that was kind of similar around professionalism. And I think, and I say this as a practicing clinician and clinical educator myself, I think we have to get more comfortable with having conversations about what professionalism is and enumerating what those behaviors really are, what constitutes a professional manner, and how to teach that and how to have the comfort level to have that conversation. It's very easy to say, this person can't be a nurse because they're just not professional. And it's so instinctive to clinicians to just get it. I know what that means, you know what that means, but they don't, so they can't be one of us. And we can't let it go there. We have to go and say, professionalism means these behaviors. I need to see you do this, this, and this for those reasons, and make it very explicit and articulate so the student knows exactly what's expected. And then if they do it, they do it. And if they don't, they can fail. And I think it's very hard for practicing supervising clinicians to fail students. It's painful. This student has been in 4 years of education and they don't get enough clinical till the end. And then nobody really wants to call the shot. It's very hard. So I think one of the answers to that is a systemic answer, which is to put more clinical and more feedback competency throughout the program so those conversations can get had and those behaviors can be articulated early on. And then people need to be able to do that at that point and say, we've worked really hard to help you understand that this is not okay behavior, and we're not willing to compromise the expectations of behavior for our client base. So you do everything you can to make it explicit, to accommodate it, to have those conversations and support the person to succeed like you would teach any other skill, right? You support the student to succeed, but sometimes they don't. And if they can't or won't, not everybody can be what they set out to be, and that's hard to face. It's hard to say, it's hard to come to terms with when what we're all about is enabling people to succeed, but sometimes they don't.
Okay, thank you. And I did scroll down a little bit, and I see that Chris has said thank you, so must be okay on answering his question there. So next question. We have lots of questions. This is really great. We'll try to get through as many as we can. So what about extra time for demonstrating skills in class versus in clinical environment when extra time is needed in clinical?
Well, that's right. Okay, that's also about how the curriculum is constructed relative to the clinical setting, right? And there really shouldn't be much difference. If what you're teaching in a clinical course is to emulate what's happening in the clinic, they should really be as close to each other as possible. So you're not making exceptions in the classroom that you're not going to make in the real world, and the real world has to accommodate too. So if it's possible to do it in one, it should be possible to do it in the other, or you haven't defined the task properly. So if you're saying, okay, you can have longer in this lab course while you're learning to mobilize a joint, and we're going to let you learn that, but when you're tested, you have to be able to do this in the same time frame you would in a clinical. That's the purpose of a clinical exam. So if there's a bona fide occupational reason that you can't take longer in the clinic, then you shouldn't be getting longer in a lab course, right? Those things have to really be synced quite tightly. The learning maybe, but in the demonstration of the skill, you can have more time to learn the thing. But when you demonstrate the skill, when you execute the procedure, clinical labs and clinical settings need to be right on each other, right? Otherwise, we're doing the student a disservice and misrepresenting the practice of the profession. That said, the practice of the profession might be able to bend a bit too. And that's where you need your clinicians and your educators really talking about how are we going to teach these students to do this procedure? Can they have extra time in the clinic or not? Why not? Well, then they can or can't have it in the classroom. Does that make sense?
Okay.
This drives me crazy. I can't see Colleen nodding or shaking her head.
That it made sense on my end.
Okay.
Colleen, if you do need any clarification at all, feel free to just unmute *7 or leave a message in the chat box later on. Okay, I think we're good. We'll keep moving on unless there's something else. Okay, next question. So we have about 5 minutes left, so we'll just keep trucking through. A number of clinical instructors continue to bring the issue of unfair advantage and or this accommodation is unfair compared to what other regular students might get. What is the legal interpretation of the terms equality and equity? In your opinion, would a defendant ever succeed against a complaint because the reasonable accommodation being requested was an unfair advantage?
Okay, good question. So first of all, accommodation is by definition not the same as what you do for other people. Otherwise, it's not an accommodation. And the notion that you're giving someone an unfair advantage, it's kind of an oxymoron because the whole point is to give them a fair opportunity, neither an unfair disadvantage nor an unfair advantage. So accommodation well done is fair because you're equalizing opportunity. And so you're not going to do the same thing for one person as another person because that other person doesn't need the same thing. So this is the principle that fair does not mean the same. And I'm not a lawyer, so I'm not going to address the technicality of what is the legal definition of equality and equity. But the principles behind equalizing opportunity mean that you do things differently because people are different. So you wouldn't accommodate somebody with rheumatoid arthritis with a computer and then have to give everyone in the class a computer because not everybody else has that need. And that's okay. So principles of law and equity have emerged to say that we are actually treating people more fairly when we meet their individualized needs for an equal opportunity, whatever equalizes their opportunity, than when we make everyone who are different from one another do things in the same way. So that you've kind of got a fundamental principle in there that's on your side. And the notion that human rights legislation requires an individualized response to that individual in that circumstance would support you in saying, it doesn't matter whether we do this for everybody or anybody ever again. This person in this setting needed it, and it wasn't contraindicated by an essential requirement, so why didn't we enable them to succeed?
Okay, thank you. So we have time for about one more question, maybe two. We'll see how quickly this goes. So regarding clinical accommodations, do we always assess accommodations on task-by-task basis? Is there any movement towards analyzing an occupation / trade / profession in terms of what people need to be able to do?
Just a second, let me catch up with your question regarding.
Sure.
I think that the answer to that, if I can even answer that question, is depends on the field you're in and how skills are assessed. And in some fields, skills are assessed very task by task at first. And as the student progresses in competency through other levels of practice, they look for more and more integration of fundamental skills with higher level skills, right? So in that sense, yes, you would be moving towards analyzing in terms of the totality of what people need to be able to do. But you still are often asked to pass, whether you can do this piece and this piece and this piece. Now we know you're ready to move on. It would be hard to imagine that you would just give somebody an end stage assessment and see if they can get there without executing the steps along the way. But it's possible that those steps along the way could be accommodated in a way that you do achieve the totality of performance at the more advanced level. Does that speak to your question?
Let's see if we have any comments. Okay, no comments or response from, I believe that was Carlene. So I think that's about all we have time for today. It's noon where I am on the dot, so we'll wrap up. I know there were quite a few questions that were left unanswered, so do feel welcome to send those questions. And there's some answers that I was interested in hearing as well. So we'll do what we can to kind of circulate some of those questions and answers as well. So you can email Barb directly with any questions that were left unanswered.
Yep. And we'll have I think we get a printout of these questions that I see were coming in, and I can answer those as well. And we'll put something together that either goes on the website with the presentation or that goes out to those who registered.
Okay, awesome. And do you have any closing comments or anything like that, Barb, that you would like to mention?
I don't think so. I just really enjoyed having this opportunity to share all of this with all of you. And just because I've moved to the States, don't think I've moved off the planet. Keep calling me. I love this work.
Awesome. Well, thank you so much for putting that together. That was a phenomenal presentation, very informative. Like we mentioned before, it's going to be posted on the Caucus YouTube channel, and the slides and everything like that will be sent out within 48 hours. to the participants, and the closed captioning will also be sent out within 24 hours to those who requested closed captioning. So thank you, Barb, and thank you everyone for participating.
Thank you. Have a wonderful day.
Yeah, you too. Take care.